Good morning. My name is Dr. Cynthia Magro. I'm the Director of Dermatopathology for Weill Cornell Medicine. Welcome to our interesting case series. So the case this morning is one that deals with a calcified neck mass in a 5-year-old female. So it was first noted in 2020, and it wasn't until 2024 that the patient underwent excision of this neck mass in concert with a partial tonsillectomy. So this mass, it was actually within the subcutis. So here we have skin and subcutaneous fat. It is a sharply circumscribed tumor. It has this pink appearance under low power magnification that clearly reflects abundant collagen deposition. So it's a fibrogenic tumor. And one can also see these interposed basophilic foci. And these basophilic foci are attributable to either calcification or inflammation. And I will go into greater detail about those additional components of this fibrotic tumor. So this is a higher magnification showing the collagen bundles are widened and have a hyalinized appearance. The calcium deposition is in the context of these laminated calcific structures that we refer to as psammoma bodies. And I would describe the fibroplasia as not really a patterned fibroplasia. And I think that's very important because when we think of inflammatory tumefactive fibrosing entities that have patterned fibrosis, that really raises diagnostic consideration only to a few entities. And what do I mean by patterned fibroplasia? The fibrosis assumes a very distinct, orderly onion skin-like pattern of fibrosis, and that is going to be exemplified by entities that are represented by IgG4-related disease, erythema elevatum diutinum, a later stage lesion of granula faciale, and the extra cutaneous upper respiratory tract equivalent referred to as angiocentric eosinophilic fibrosis. So the fact that the fibroplasia in this case is not patterned would make these particular entities less likely. So what about the inflammatory foci? Well, the inflammatory areas were very distinctive. They were composed of germinal centers that were depleted in centrocytes and centroblasts, hence they were atrophic. They were also hypervascular. You can see how a number of thick-walled blood vessels are penetrating these atrophic germinal centers. In addition, when one examines the mantle zone of small lymphocytes around the atrophic germinal center, they had this distinct laminated onion skin-like pattern, which is quite interesting. And what is it attributable to? Well, the CD21 stain highlights a unique germinal center mesenchymal cell referred to as the follicular dendritic cell. And one can see that these germinal centers had a very robust follicular dendritic cell network that actually extended into the surrounding mantle zone to define the lattice, if you will, upon which the lymphocytes would scaffold to produce that distinct laminated onion skin pattern. Over and above these hypervascular atrophic germinal center foci with that distinct onion skinning of lymphocytes, another component of the inflammation was in the context of plasma cells. So there were a number of plasma cells that were typically at the periphery of the lymphoid nodules. They were highlighted by IgG with minimal staining for IgG4. They were polytypic. So to summarize then, we have a hyalinizing, fibrosing lesion in the fat without a well-developed patterned fibrosis, like one sees in IgG4-related disease or erythema elevatum diutinum. There was significant calcification, including psammoma body formation. The germinal centers were distinctly atrophic, hypervascular, associated with CD21 follicular dendritic cell prominence, with a resulting onion skin-like pattern to the mantle zone lymphocytes, and as well their polytypic plasma cells. So the diagnosis that I had rendered in this case was a calcifying fibrous tumor with concurrent features of mixed hyaline vascular or hypervascular Castleman's and plasma cell Castleman's disease as a profibrogenic fibrotic phase of unicentric mixed hypervascular plasma cell Castleman's disease. So that was my diagnosis. So calcifying fibrous tumor was first recognized in 1988 by Rosenthal and Abdul Karim, where the lesion was described in 2 pediatric patients who presented with a soft tissue mass in the axial skeleton characterized by nodular fibrosis and seminoma body formation with a variable lymphocytic and plasmacytic infiltrate. There is a predilection for females with a trimodal age distribution, 0 to 5 years, patients in their 20s, patients in their 30s. Calcifying fibrous tumor, in fact, has been associated with unicentric Castleman's disease in 6 prior anecdotal case reports. And I think it is reasonable to state that calcifying fibrous tumor is probably a profibrogenic variant of unicentric Castleman's disease, at least in a substantial subset of cases. So the whole conceptualization of Castleman's disease really began back in 1956 when Benjamin Castleman, Lala Iverson, and Parda Menendez wrote their seminal paper that described unicentric hypervascular Castleman's disease. They used the designation of localized mediastinal lymph node hyperplasia resembling a thymoma clinically and to some extent histomorphologically. And so the lesions, they arose from the mediastinal lymph nodes, and they had this very characteristic finding in the lymph nodes, which were in the context of germinal centers that actually resemble Hassel's corpuscles of a thymus, but they were in fact these atrophic germinal centers where there were these vertically oriented angulated blood vessels that were coursing through the atrophic germinal center with the variable onion skin-like laminated mantle zone. So really very, very distinctive and certainly mirroring the findings that we have in our case. Well, since the original description of unicentric Castleman's disease back in 1956, we have expanded our understanding of Castleman's disease and our classification of Castleman's disease to encompass unicentric Castleman's disease and multicentric Castleman's disease. And initially, multicentric Castleman's disease was divided into cases associated with HHV positivity, which was first described in 1995, versus those that were negative, so-called idiopathic multicentric Castleman's disease. In unicentric Castleman's disease, we have a single enlarged lymph node or an extranodal site. For example, we have involvement of the subcutaneous fat in our case. It's presumably idiopathic. These patients are largely asymptomatic, but of interest in mediastinal unicentric Castleman's disease, a very deleterious sort of paraneoplastic sequelae is paraneoplastic pemphigus. In addition, if one is to assume that the folliculodendritic cells may actually be clonally restricted in a subset of these cases, that might explain why some patients with unicentric Castleman's disease can develop a folliculodendritic cell sarcoma, and those cases can become quite difficult to resect. So those are the sort of situations where these idiopathic unicentric Castleman's disease cases would be associated with very significant symptoms, either paraneoplastic pemphigus or if they are unresectable because of the ensuing folliculodendritic cell sarcoma that might develop. Now, in multicentric Castleman's disease, associated with HHV8, there is invariably a history of immunosuppression, usually human immunodeficiency virus infection. These patients are very ill. They have flu-like symptoms, they have multiple organ impairment, renal failure, pancytopenia, fluid gain. The HHV8 lives in plasma cells, and there is the encoding of the viral IL-6, so that much of the symptomatology in HHV8 multicentric Castleman's disease relates to high levels of IL-6. It's a type of hypercytokinemia, if you will. In the idiopathic multicentric Castleman's disease, the unmet cause is unknown. Again, we have a cytokine-driven process with involvement of IL-6, flu-like symptoms, multiple organ system involvement, and these patients can potentially respond to anti-IL-6 therapy. Well, as it turns out, multicentric Castleman's disease now recognizes a third category. In 1992, there was the first reported case of multicentric Castleman's disease associated with POEMS syndrome. And POEMS syndrome is an acronym for patients who have peripheral neuropathy, organomegaly, endocrinopathy, monoclonal gammopathy, and skin lesions. And subsequently, other cases were reported such that we now have broadened and finalized our classification of Castleman's disease to the unicentric, as we've discussed, and the multicentric, for which we now have three broad categories: POEMS associated, HHV8 associated, and idiopathic. And very importantly, in the idiopathic category, we have three subtypes. We have patients that have Tafro syndrome, where they have thrombocytopenia, they have anasarca, reticulum myelofibrosis, and organomegaly. We have idiopathic not otherwise specified, and then we have something referred to as idiopathic plasmacytic lymphadenopathy. So in that multicentric idiopathic category, there are those three particular subtypes. And what about the pathology of Castleman's disease? Well, there are really two very important broad sort of spectrums of pathology. One is the hypervascular pathology or hyaline vascular pathology, where you have these regressed germinal centers depleted in centrocytes and centroblasts with CD21 positive follicular dendritic cell prominence. And there's hypervascularity, not only in the germinal centers, but in the interfollicular tissue. At the opposite spectrum, we have the plasmacytic pathology, where you have a lot of plasma cells, and the germinal centers, instead of being atrophic, are hyperplastic. And the reality is that many cases of Castleman's disease, whether you're dealing with unicentric or multicentric, fall into this mixed category, where the biopsy shows features of both hyaline vascular and plasmacytic Castleman's disease. So there are certain diagnostic criteria for idiopathic multicentric Castleman's disease. There is the major criteria where you need both. These patients invariably have lymphadenopathy. They have a lymph node biopsy that is confirmatory of Castleman's disease, either hyaline vascular, plasma cell, or mixed. And then there are minor criteria, where there is at least 2 of the 11 criteria with at least 1 laboratory criteria. And so what are the laboratory criteria? Elevated ESR, anemia, thrombocytopenia, or thrombocytosis. Remember, in Tafro syndrome, you have thrombocytopenia. Renal dysfunction, polyclonal hypergammaglobulinemia, hypoalbuminemia. Now we'll go into the clinical symptoms, constitutional symptoms, splenomegaly, hepatomegaly, fluid accumulation. And because of the elevation of vascular endothelial cell growth factor, these patients can develop unusual benign vascular proliferations in the skin, lymphocytic interstitial pneumonitis. Well, very key to the pathogenesis of unicentric and multicentric Castleman's disease is hypercytokinemia, with the main, but not only, but the main cytokine implicated being IL-6. So, in the virally driven hypothesis, that is HHV8, Castleman's disease, the virus has a proclivity for plasma cells. There is the encoding of the viral IL-6 by the plasma cells. So the plasma cells produce IL-6, and IL-6 in turn actually will be promotional to plasma cell hyperplasia. In the paraneoplastic hypothesis, the neoplastic plasma cells in the setting of Poems syndrome, or possibly the clonally restricted follicular dendritic cells, they will be the source of IL-6. And then in the autoinflammatory or autoimmune setting, you have upregulation of interleukin-1 that will stimulate IL-6. So again, we have paraneoplastic, viral, or autoinflammatory / autoimmune. And I think it is reasonable to state that in many cases, interleukin-6 is a key driver. Interleukin-6 is produced by T cells, but it is also produced by plasma cells, histiocytes, follicular dendritic cells. It is a cytokine with pleiotropic activity, and many of the laboratory criteria that we see in Castleman's disease, in fact, is linked with high levels of IL-6. The C-reactive protein, amyloid, fibrinogen upregulation, also the hypoalbuminemia that we see in patients with Castleman's disease, that's an IL-6 sequelae because of its inhibitory effects on albumin production. Vascularity, whether it's vascularity of the germinal centers, the benign vascular neoplasms that these patients can get, that relates to upregulation of vascular endothelial cell growth factor by IL-6. IL-6 promotes plasma cell growth and probably is a key factor in the plasmacytic pathology that we see in Castleman's disease. Also, if you remember, in plasmacytic Castleman's disease, there's germinal center hyperplasia, and that is probably an IL-21 effect, which in turn relates to IL-6. Also, when we look at our patient with the calcifying fibrous tumor, where you have all that fibrosis and calcification, IL-6 promotes TGF-beta, which is very key for collagen production, and at the same time, it promotes ectopic calcification. So you can see how IL-6 may actually be the basis of the calcification and fibrosis that we see in the calcifying fibrous tumor, which again I think is this profibrogenic expression of unicentric Castleman's disease. Now my colleague, Dr. Jerry Nuovo, was kind enough to do an interleukin-6 on our case of calcifying fibrous tumor, and what we discovered was that the IL-6 was definitely upregulated, and it was localized to histiocytes and CD8 lymphocytes. It actually was not coming from the follicular dendritic cells that are residing in the atrophic germinal center and extending into the surrounding mantle zone. And just to summarize those other cases of calcifying fibrous tumor with concomitant Castleman's disease, there were 6 other cases. So we have a total of 7 cases if you include our case. And of interest, 4 of the cases had the calcifying fibrous tumor adjacent to a lymph node that was affected by Castleman's disease. Well, in 3 of the cases, the calcifying fibrous tumor was with concurrent Castleman's disease within the lesion, be it in an extranodal context or in an intranodal context. And also I'd like to draw to your attention the relatively young age of the patients that are affected. So of the 7 patients, you have 1, 2, 3, 4 that are in that pediatric age group. Dr. Cotti is an outstanding Cornell pathology resident who has a keen interest in dermatopathology, and he's been working with me on this review on cutaneous Castleman's disease. And so we're basically going over our experience with cutaneous Castleman's disease from the Cornell Dermatopathology database, and we were able to discover 8 fairly unequivocal cases, of which 7 of the cases were unicentric. Virtually all of them were in the subcutis, and we had 1 case of multicentric Castleman's disease. And there may be a few other cases that we're still working on that we may potentially add to this series. And what can we say about unicentric Castleman's disease of the skin? Well, an interesting feature is that this entity does occur in the subcutaneous fat. When you look at pseudolymphoma of the skin, it almost invariably is a dermal process with variable extension to the fat. Certainly, Castleman's disease of the skin, there's a lot of lymphoid hyperplasia, but it is one of the rare entities where that lymphoid hyperplasia, instead of being in the dermis, is actually in the fat. So that's number one. Number two is, unlike unicentric Castleman's disease of the mediastinum, where those patients can have a large unresectable tumor with symptoms, they can develop follicular dendritic cell sarcoma, potentially, it's rare. They can develop paraneoplastic pemphigus. Subcutaneous Castleman's disease is relatively asymptomatic. And I would say that the typical pathology is a combination of hypervascular Castleman's disease with atretic, centrocyte and centroblast depleted lymphoid follicles, with hypervascularity, interfollicular hypervascularity, and oftentimes with a plasma cell component. So really a mixed pathology. A CD21 stain is very useful because it does highlight the rather striking follicular dendritic cell hyperplasia, including the extension of the dendritic cells to really encompass the mantle zone and that lattice pattern that imparts the onion skin morphology to the mantle zone. And this is just a low power of the sort of classic presentation we expect to see in subcutaneous Castleman's disease. So it is one of the rare entities that can produce a circumscribed nodule in the fat with lymphocytes, with coalescing lymphoid nodules resulting in this circumscribed subcutaneous tumor, if you will. Now, our one case of multicentric Castleman's disease is certainly noteworthy. Why? Because I think it is prototypic for pretty much multicentric Castleman's disease presenting in the skin. First of all, the patients have multiple lesions, and the lesions have this very distinct quality that I think is attributable to all the plasma cells. It's reddish, they're reddish-brown lesions. So they're multiple reddish-brown lesions. And this patient, in fact, was subsequently discovered after the biopsy to have lymphadenopathy that showed diagnostic features of Castleman's disease. She had hypergammaglobulinemia and an elevated ESR. So if you go back to our chart, she in fact fulfilled criteria for idiopathic multicentric Castleman's disease. So what did her biopsy show? Well, the biopsy, unlike unicentric Castleman's disease, the lymphoid hyperplasia was in the dermis, and there were germinal centers, and the germinal centers were noteworthy because of their hypervascularity, which again is a vascular endothelial cell growth factor effect. The germinal centers ranged from being somewhat hyperplastic to being centrocyte and centroblast depleted. In addition, there were many plasma cells, and the plasma cells were lambda light chain restricted. Yet this patient did not have any evidence of a monoclonal gammopathy. And I think it is important to remember that in idiopathic multicentric Castleman's disease, where you have this plasmacytic pathology or a mixed pathology, that you can actually see lambda light chain restriction in the plasma cells without that finding necessarily indicating a plasma cell dyscrasia, which was certainly the case. And why it's lambda light chain restriction is interesting. It's a bit of an enigma. I don't know. And I'll conclude this session with a comment about Castleman's disease and lymphoma. So there is definitely a higher incidence of lymphoma in Castleman's disease. There are a number of papers that are devoted to this topic, such as the one by Claire LaRoche and her colleagues entitled Castleman's Disease and Lymphoma, Report of 8 Cases in HIV-Negative Patients, and Literature Review. So probably the most commonly reported lymphoma is Hodgkin's lymphoma, and it typically occurs in unicentric Castleman's disease and usually affects the same area involved by Castleman's disease and has a great prognosis. However, one can also see lymphoma in multicentric Castleman's disease, and it is non-Hodgkin's lymphoma, where the majority of the cases are B-cell lymphomas, and there is this interesting overrepresentation by mantle cell lymphoma. And patients who have multicentric Castleman's disease, where they are already very ill, when they develop non-Hodgkin's lymphoma, it can be very aggressive. So that's it. That's today's interesting case. I hope you found it, a fascinating case. I know I certainly find the topic of Castleman's disease very intriguing and interesting. And as you know, all these slides are available for downloading and for your own use. And I thank you for your attention.